Hi, this is Dr. Dave Kirshner, and this presentation will be on fractures of the upper extremity. We will really only be covering two types of fractures, supracondylar and distal radius fractures. Why just these two? Well, the data supporting ultrasound in the ER is the most robust for these two types of fractures. We will not be covering Salter-Harris fractures, as imaging fractures at growth plates is very difficult, and studies have shown we are not good at picking them up in those locations. But why ultrasound fractures at all if we can get definitive imaging? A couple reasons come to mind. Firstly, ultrasound can be used more rapidly than X-rays to help during fracture reduction. We can use it at the bedside in the midst of the reduction to show that the initial fracture has or has not been reduced adequately. This could have potentially negated the need for resedation in this patient, along with all its inherent risks. Secondly, as some fractures are assessed for by identifying indirect findings, such as fluid in a joint, we can learn to transfer these findings to other clinical scenarios. For example, is this a cellulitis or a septic elbow? Thirdly, it's a way in which we can educate our patients and share with them at the bedside how we come to our diagnosis, so they also have a better understanding of it. I have yet to have a parent not be amazed when I outline the distal radius fracture their child has, as I show them all on the screen right in their exam room. And finally, there are some physicians who will work in environments that do not have formal imaging capabilities. Is this a patient that needs to be sent away for imaging? Can this be managed in community? So getting back to actually imaging these parts of the body, we will go over how to image the distal humerus and the distal radius, looking for fractures in these areas. This is a chart outlining, in general, some of the easy-to-see fractures, as well as those that are more difficult to see. This table is not all-encompassing, but gives a flavor of some fractures that can be seen. As you can surmise, based on this very brief chart, long bone fractures are much easier to visualize because it's easier to see a break or step in the smooth, bony cortex, which appears hyperechoic or bright white on ultrasound. Now you might be saying to yourself, supracondylar fractures are listed under difficult fractures to see. Shouldn't we be starting with easier fractures? Well, yes and no. In the case of supracondylar fractures, it is difficult to see the fracture itself in most cases, but it is easy to see a reliable indirect finding of such a fracture, and we will come back to that in a bit. The other reason we can still start with learning to identify them is because of volume. There are so many children that present with Fuchs injuries and potential supracondylar fractures that it is easy to practice on many children within a relatively short period of time. But getting back to the indirect findings, if you can't see the actual fracture, you can still look for the following findings: a displaced fat pad in the joint, fluid in the joint, soft tissue edema, torn ligaments, blood in the joint, and hematoma overlying bone. Now, 3 of these findings don't help us with long bone fractures, not that we needed that much help anyway, but they do help us with fractures that extend to within a joint capsule, such as a supracondylar fracture. Did you like that segue? So how do we look for elbow effusions, regardless of what's in them? In our patient population, we will mostly be concerned about supracondylar fractures, but we can still see joint effusions with radial head fractures, elbow dislocations, olecranon fractures, and other pathology within the joint space. The 2 binary questions that we will be asking ourselves in the evaluation of the elbow are: is the posterior fat pad still plastered against the olecranon fossa? And is the posterior fat pad displaced above the dorsal humeral line? Now, out of these 2 questions, the first one is the most important, although the second one can still add some information. We will be imaging the distal humerus primarily from the posterior approach. It is best to have the patient sitting upright with their elbow held in flexion. While it is still possible to see the elbow effusion with the elbow and greater extension, it can be difficult to keep the probe on the area of interest without slipping off to one side or the other. Place the probe in the long axis of the humerus on the dorsal aspect of the humerus with the probe marker proximally. Begin over the mid-humerus and slide the probe distally. This is the maneuver you will be performing in real time. Of note, you can stabilize your hand against another part of the patient's arm if required and if it's not too painful. Now let's look at the area of interest on the screen and then we will put the two pieces together. The key anatomic structures to identify on this image, which is our area of interest, include the distal humerus, the posterior fat pad in the olecranon fossa, and the triceps muscle with overlying subcutaneous tissue. To help orient yourself to what you will see on screen, think of the distal humerus in this orientation. On the screen, you will see the bright white horizontal line on the screen, which is the posterior humeral cortex. As you slide distally, or to the right, you will see it gradually drop to the bottom of the screen, and this is the olecranon fossa. And this is what you will see. Again, there is a hyperechoic bright white horizontal line which will fall off into the olecranon fossa, which is filled with the posterior fat pad. The overlying triceps muscle will have hyperechoic linear striations visible within it. Again, here is the distal humerus, the posterior fat pad within the olecranon fossa, and the triceps muscle with overlying subcutaneous tissue. Now, this is the ultrasound image we want, and this is its location relative to a radiograph of the distal humerus. Again, here's the distal humerus, the posterior fat pad within the olecranon fossa, and the triceps muscle with overlying subcutaneous tissue. We can also view the distal humerus from a posterior approach in its short axis, or transverse view. We again begin over the mid-humerus posteriorly and slide the probe distally until we identify the olecranon fossa. This is what the view will look like on the screen as you slide from proximal to distal in the transverse plane. Here is a view of the olecranon fossa. I tend to think of it as a valley between two hills, which are the posterior aspects of the condyles. Again, we can identify the triceps muscle, the posterior fat pad within the olecranon fossa, and the humerus. If we look at the olecranon fossa and follow its contour, we see that the posterior fat pad is adherent to it. Admittedly, I used to think that it was enough to draw a straight line that continued on from the posterior humeral line and would ensure that the fat pad fell beneath this line. The problem is that if this is your sole criteria, you could get an effusion that is so small that the posterior fat pad isn't adherent to the bone in the olecranon fossa, but not big enough to displace it beyond that line. Therefore, look to see if it's adherent or not. If we look in the transverse view and draw a line along the olecranon fossa posteriorly, and then identify the posterior fat pad, we see that it is again well seated in the olecranon fossa. Now I know we are moving quickly, but which elbow has the effusion and is therefore more likely to have a fracture associated with it? We start by drawing a line that continues along the posterior cortex as it dives into the olecranon fossa. Does the posterior fat pad stay tightly adherent to the olecranon fossa? Well, it does in the image on the left, but not in the image on the right. The image on the right has the elbow effusion. Can you outline the posterior fat pad here? Is it tightly adherent to the olecranon fossa? No. In this effusion, there is blood that is visibly displacing the fat pad, as well as an area that is likely a mixture of blood and fat. When you can make out the layer distinction of blood and fat, it is called a lipohemarthrosis, and it is more commonly associated with a fracture than a bony contusion or ligamentous injury. How about this elbow? Well, it's already done for you, but if you were to mentally draw out the posterior humeral cortex as it dives into the olecranon fossa, you would see that the posterior fat pad is not tightly adherent to it. Therefore, an effusion is present. How about this elbow? Well, it doesn't look normal. Unfortunately, this image doesn't show the entire olecranon fossa. The fat pad seems to be displaced posteriorly, and there also seems to be a small amount of fluid between the triceps muscle and the posterior humeral line. This is a clip of the same patient as the image is swept from side to side. Now it's clear that the fat pad is indeed displaced posteriorly. This is a transverse view of a lipohemarthrosis. Again, note the differing echogenicity of the material and that it extends above the posterior aspect of the condyles. Here is another significant lipohemarthrosis. This one hasn't layered out as nicely. It is more likely to see layering if the patient has been holding their arm in the same position for a longer period and if it's been longer since the fracture occurred. Do you recall the case from the beginning of the presentation where we were questioning if there would be an underlying septic joint or not? Whether the fluid in a joint is due to infection, fracture, or inflammation, it should still displace the posterior fat pad. In this case, this was the ultrasound of the distal humerus. Do you think there is a joint effusion in this elbow? No, probably not. The posterior fat pad is well seated in the olecranon fossa. Can you identify the subcutaneous tissue? Does it look normal? There seems to be extra fluid within the subcutaneous tissue, which is in keeping with the cellulitis this patient has. While the patient does need antibiotics and follow-up, at this point they do not warrant an aspiration of the elbow joint. Of note, too, is the shadow that we are seeing in the right lower corner of the screen. It is the trochlea and its shadow. So that is the basics of assessing the elbow joint for an effusion, which is an indirect finding of pathology. All right, moving on to distal radius fractures. In this case, we are looking for the actual fracture line, a disruption in the cortex of the bone. Now, depending on the type of distal radius fracture, the disruption can be in different places. Again, we will begin over the dorsal aspect of the bone in question in the long axis and will slide distally. Depending on where the fracture is, we may need to slide as far as the radiocarpal joint. We're going to repeat the above process along the radial and volar aspects of the distal radius. Like with radiographs, relying on just one view is inadequate to fully assess a bone for fractures. Here's a video of the movement that will be performed. Note how the hand is stabilized by the 5th digit, which is against the child's arm. And again, here are the dorsal, radial, and volar approaches. Does anyone notice anything wrong with these images? Well, in theory, the probe marker should be pointing proximally. While I am sure there are purists out there who would be upset, either way works as long as you have the orientation correct in your mind. This is the view you will see as you slide distally. A hyperechoic, smooth, bony cortex that becomes rounded at its end. You can see the scaphoid bone to the right in the far field distal to the radius in this view. The clip in this case was taken with a different filter, and the person had the marker pointing proximally. In this view from a radial approach, one can still appreciate the smooth, bony cortex. And finally, the volar approach. Now, how old do you think this patient is? We can't say for sure based on these images, but we know they are at least old enough to have their distal radius growth plates closed. This is what a distal radius looks like from a dorsal approach in a skeletally immature patient. The cartilage appears beyond the metaphysis of the bone and is surrounding the epiphysis. Note how smooth and rounded the contour of the cartilage is. This is different than the shape that free fluid or an effusion would take, as it fills in cracks and crevices and doesn't have a nice smooth contour like this does. If we were again to draw a line along the dorsal aspect of the bone, the cartilage would not extend beyond that line. This image shows a lateral or radial approach to the same patient from the previous image. Now that we've looked at a couple normal distal wrists, let's look at some pathology. Remember, in this case we are looking for the actual fracture, the disruption to the normally smooth, bony cortex. Is there a disruption in the smooth hyperechoic line, which is the bony cortex? Yes, there is. We can follow the smooth, bright line as the image moves to the left, when suddenly there is a step deformity. The bright line stops abruptly and restarts at a different depth. This is what a fracture looks like. In this case, this was a dorsally angulated Colles fracture. How about this distal radius, taken from both dorsal and radial approaches? Here is the fracture seen on the dorsal view, and here is the fracture seen from the radial view. There is a disruption in the smooth, hyperechoic line that is the bony cortex. Now, knowing we've only reviewed two fractures and two normal studies, let's try to put our skills to the test. Is there a fracture? Well, yes, there is. I realize there's the caliper sign showing how far apart the parts of the bone are, but even without that, we can see that there is a disruption in the normally smooth line of the bony cortex. So next part of the question. You are performing the procedural sedation for this patient, and our orthopedic colleagues are attempting to reduce the fracture. After 3 attempts, they think they have the bone back in place. You take a look with the ultrasound from the dorsal and the radial aspects just before they apply the cast, and this is what you see from a dorsal view. Is this reduced adequately? No, it's not. It looks almost exactly the same. Of note, the shaded area is the hematoma. If you are ever considering doing a hematoma block, ultrasound allows you to identify it with greater accuracy. These are the pre- and post-reduction radiographs that went along with this patient. While there has been some success in getting the distal fracture closer to length, it is still off the proximal portion by a significant amount. How about this fracture reduction? The pre-reduction is on the left and the post-reduction images are on the right. So first, we identify the hyperechoic smooth bony cortex and see that in both cases there is a disruption of it. That being said, the disruption is far less in the post-reduction image than in the pre-reduction image. How about this distal radius? Is there a fracture? Yes, there is. While there is no big step in the cortex of the bone is not smooth. There is an acute angle located in the middle of the screen. And this is what the bone might look like on radiograph. A small hematoma is again noted between the dorsal bony cortex and the overlying tendons, which appear linear and horizontal. Let's next address what buccal fractures would look like. The buccal fracture probably jumped out at you in this clip. The hyperechoic line of the bony cortex is present, but when we follow from right to left, there is a sudden bulge to it. This is the corresponding X-ray, with the buccal fracture noted on the distal radius. So how would we tell the difference between a buccal fracture and a greenstick fracture? To do that, we would need to image the volar aspect to determine if there is any disruption to the smooth, hyperechoic bony cortex there. Now these are the dorsal, lateral, and volar views of the patient from the previous slide. Based on these images, where else do you think we will find a cortical disruption on X-ray? Well, likely on the radial aspect of the bone, best seen on an AP view. And sure enough, there is a slight irregularity there. One last buccal fracture, as they can be more difficult to see. In conclusion, then, remember, look for the indirect finding of a displaced posterior fat pad in elbow fractures. And look for disruptions in the smooth bony cortex for distal radius fractures. And don't forget, when in doubt, compare to the opposite side if that helps. Thanks for watching and happy scanning.